In the comments section of a social media psychiatric page, a young woman, declaring herself to be 21 years of age, wrote,
"My boyfriend always seemed normal enough to me, but recently he has been sent to a mental hospital. I know he has anger problems and he has been saying that someone is plotting against him and that everyone is talking about him."
The more she writes, the more her defences unravel.
Sometimes he would talk about things, and I would try to tell him he wasn't making any sense. To be honest, I did feel that something was wrong with him, but I always ignored it. I guess I was in denial.
Until the truth was inescapable.
Now I think about it, things got pretty dangerous when he was so sure someone was trying to harm him.
The doctors diagnosed him with schizophrenia. Schizophrenia has a long history and has become a word synonymous with severe mental illness and a socially disabling state of mind. The Ebers Papyrus from ancient Egypt indicated symptoms of schizophrenia around 1550 BC. Some of the conditions include hearing voices, seeing visions, erratic behaviours and fluctuating moods including melancholy and mania, which can be found in various medical records and fictional literature across the centuries. The condition was described as dementia praecox in the late 1800s by a number of people, including Heinrich Schul, Arnold Pick, and Emil Kraepelin. The word schizophrenia was coined by Eugene Bleuler in 1908, which translates from the Greek roots as splitting of the mind. We asked psychiatrist Dr. Larry Ozawara, Senior Medical Director at Valera Health, how schizophrenia is described today.
And the way that I would conceptualize it is a diagnosis or disorder of mostly a distortion of reality and some cognitive disturbances, right? So that distortion of reality or the psychosis component really takes the form of either hallucinations, like hearing voices that aren't necessarily there or seeing things that aren't necessarily there, and also delusions, thinking something that is true when it actually isn't. On the other side are the cognitive ones. So that's really a disturbance in how they think. And the problem with that is that you can't really know what somebody's thinking, right? You can't read minds. The way that you can kind of get a sense of that is to look at their speech and look at their behavior as a reflection of how they're thinking cognitively. The disorganized speech and disorganized behavior in combination with the delusions and the hallucinations really make up the bulk of what we call positive symptoms of schizophrenia. And when we say positive, we're not thinking these are great symptoms to have. It just means that the presence of symptoms that should not be there. On the other hand, there are some negative symptoms that are a little bit harder to catch because they are symptoms that are lacking, not motivated, who are not social, who are very withdrawn. They're not doing the normal things that a person would typically be doing. Those are really the negative symptoms of schizophrenia. And as it turns out, those are much harder to treat than the positive ones.
So things are very different today. But the management of mental diseases over the centuries has not been praiseworthy. Institutions for the mentally ill were called asylums, and the patients insane. Asylums housed the insane, who in many instances were effectively imprisoned. The word bedlam, which is used to describe a scene of madness, chaos, or great confusion, comes from the nickname of one of the most infamous mental asylums in England. The Priory of the New Order of Our Lady of Bethlehem Hospital began to care for those considered insane in the mid-1300s, although the first official record is from 1403. Inmates deemed dangerous or disturbed were chained or locked up. Clergyman and writer Donald Lupton wrote in the 1630s of the, quote, cryings, screechings, roarings, brawlings, shaking of chains, swearings, frettings and chafings, unquote, that were amongst the horrors of being an inmate in Bedlam. Kraepelin and others deemed schizophrenia as an incurable and inexplicable madness. But much has changed in the way schizophrenia is dealt with by medical practitioners and how it is personally managed. Nowadays, many people live meaningful and satisfying lives with schizophrenia. We will share in the life experience of 4 fascinating and courageous human beings, Risa, Andrew, Chris and Ian, and of course explore the science and the research that is opening up new doorways of understanding.
It's possible that even though you've been to the darkest pits of your life, you can see the light and it can get better, it can improve. But it's up to you. Recovery is different between different people. So recovery can be, for me, it's different. My recovery for me was getting a job again and getting my license back again. So slowly building my life back again, because for a long, long time, everything's been taken away, like my driving, my job, everything, even relationships I haven't had for a long, long time. But just rebuilding it slowly. But recovery is different for different people. And some people, recovery can mean just getting up in the morning and having a shower.
So I guess the major challenge that my illness presents with is the auditory hallucinations, testing reality and not knowing what really is real and what is not real. So I take some medication to help me with that, and there's quite a deal of processing that happens around what I think and what I feel to try and work through what appears to be reality and what isn't. So that's a bit of a challenge, some mental gymnastics, testing reality.
To have a normal life, and if I didn't have that, I don't know where I would be, or but like you get the hallucinations from time to time, but one of the things, I'm a man of faith, and that has been the other rock, you could say, like the bigger rock in my life. It just always have faith that whatever you're going through, you will get through it, and that you will get through to the other side of what you're going through.
Vulnerability is my symptoms around schizophrenia, and what that experience is like for having thoughts and emotions that have basically put me in a vulnerable place. Trying to rationalize things myself and coming to my own conclusions, and believing in things that are irrational. That's how the symptoms play out, and thinking more of myself than what I am.
Being able to live with schizophrenia has become more possible as research has provided a better understanding of what is happening in the brain and in the body, and better ways to manage the symptoms. The Queensland Brain Institute is producing world-leading research.
So I'm trying to work out what actually happens in the developing brain that puts the brain and certain circuits on a different road. We know that these disorders that I work on have a developmental basis. We've known this for a good 40 years. I'm trying to work out what are the circuits that go on a slightly different journey, because it's not a massively different journey. It's because we don't have hydrocephaly, we don't have big changes in any particular part of the brain. The brains outwardly of my brain and an aged matched person with psychosis, for instance, would look the same. There are small little changes, but really they're not anything like a diagnostic change. So I'm trying to work out what goes on inside the circuits to make them dysfunctional.
We've known for a long time that dopamine is involved in psychosis. Antipsychotics, which were developed in the 1950s and 60s, all block dopamine systems. They try to stop dopamine signaling. So if you stop dopamine signaling, you can reduce psychotic symptoms. If you take drugs that stimulate dopamine, like amphetamines, they can induce psychotic symptoms. So we've known that relationship for a long time. And as technology and science improved, our ability to look at using radio tracers in someone who's awake and healthy, or someone who's experienced psychosis, we could look in their brain and see what neurochemical abnormalities they had. That confirmed all these hypotheses. In a lot of people with psychosis, they have these increased dopamine systems.
These avenues of research are refining what we have known about brain development and the dopamine pathways in the brain. There are 4 different dopamine pathways, and each has a different effect. In broad terms, the nigrostriatal pathway is involved in the production of movement. The mesolimbic pathway is involved in motivational cognition and learning. The mesocortical pathway is involved in prefrontal cortex function and emotional control. And the tuberoinfundibular pathway is involved in the production of prolactin, which stimulates breast milk and maternal behaviour. Schizophrenia has been connected to increases of dopamine in the mesolimbic pathway. Our researchers tell us that this interpretation is no longer accurate.
The lateral neurons, they're the A9 dopamine neurons in the brain, they are the area that people, maybe some of your subscribers have heard about, are the neurons that will degenerate in Parkinson's disease. Lose 80% of them, you get Parkinson's disease. But these neurons project not exclusively, but primarily to an area of the brain called the dorsal striatum. That is where all the dopamine abnormalities are in schizophrenia. All of them. They're all in the dorsal striatum.
As our cameras and technology got better, we could start to see which parts of the brain in particular those things are associated with. And that was, I think, sort of a decade, 15 years ago, was sort of a breakthrough, at least in my perspective of it, of where the increased dopamine that was related with psychosis was actually located in the brain. We always thought it was this sort of motivation reward system, the limbic system we call it, because that just made sense for like salience and misattributing things that shouldn't be relevant. They become relevant, and that can sort of, induce some of the psychotic symptoms. But what it turned out to be was a little more sort of this direction of the brain, so up in what we call the associative striatum, which in a human is primarily the caudate nucleus. And what that meant was that things weren't quite as simple.
This breakthrough in understanding where the dopaminergic problem lies means that the approach to therapy and medication will have to adjust. It reminds us that we must continue to question and explore and make corrections that develops more effective treatment strategies. James Kesby explains.
The problem with the associative striatum is it's a much more complex region. There's no very simple, if we put too much dopamine in here, we'll have this outcome with this little simple test. But it's incredibly important for all the incoming cortical information that we navigate decisions with. So all these, it's dopamine projecting to this region, but it's a whole bunch of glutamatergic inputs from various cortical regions, which are the associative cortices, hence its name. And what it does is it takes all this information, different brain areas are involved in computing different things. So, is anything changed? No. What's the best strategy we can do to this? How are we going to approach this? Is it relevant? All these things coming in, and then it sort of navigates the whole process to go, okay, how are we going to act upon this? What are we going to do? And what's our strategy moving forward? And maintains that so we can consistently make good choices. So obviously that's very complicated. So that's what we're looking at now to try and understand. So if we have too much dopamine in this region, does it impair our ability or its ability to navigate all these incoming problems from the cortex? And it gets even more sort of complex when you think about how we treat psychosis. And not all, obviously it's a very broad disorder. It's one of the problems with these severe psychiatric illnesses, especially schizophrenia, is that there's a lot going on. It's not just dopamine. There's lots of different disorders get psychosis.
Daryl Isles' developmental research is revealing another view of this complex picture.
Now, my task is to try, potentially arrogant task, is to try and get us closer, a step closer to understanding the neurobiology of a disorder like schizophrenia. So, some of the other things we know about schizophrenia is it's a developmental disorder. I dare say almost every psychiatric condition that doesn't come from neurology, say an acute stroke or something, every psychiatric condition is a developmental condition. They have developmental origins. Schizophrenia is no different. It's said that the heritability of schizophrenia is about 80%. But we also know there are environmental contributions. There are late onset environmental triggers. We have known, this is extremely robust, that drug exposure, in particular to tetrahydrocannabinol, is throughout the world associated with increased incidence of schizophrenia. We also know that late stress events that happen in a person's life, these could be associated with hormonal events, or they could be just associated with the stress of being a young person finding your way in a difficult world when there's lots of rearrangements happening in the brain. I came across this phrase the other day, which I really liked: moving parts break. And in a teenage brain, there are lots of moving parts in terms of myelination, in terms of circuit refinement. These things are going on, so things are moving and they can break.
And so it is the break, or the breakdown, that can suddenly change people's lives.
I had my first nervous breakdown in 1999 when I started hearing things and I started feeling things that wasn't there, and my parents were just amazing in supporting me throughout my journey. So yeah, I'm very lucky. But and my family, so the rest of my family have been supportive throughout my journey. But yeah, just hearing things and feeling things that are not there, and being in a different dimension, but just being in its physicality, but being in a spiritual dimension. And I do believe there's different.
I moved out of home to Brisbane. I'm from a country town called Moree. So it's a big move interstate. And I think that would have been where the first big change happened for me with schizophrenia. So I went and saw a psychiatrist, but I guess the first thing is denial. I just tried to push past the pain and try to live a normal life.
And within a short period of time I became paranoid, delusional, had changes in weight, changes in appetite, changes in sleep, and I had a relationship breakdown. So I ended up resigning from the pulp and paper mill, going to live with a chaplain and his wife and create a suicide intervention and prevention retreat. And then Mum and Dad had to fly down to Tasmania to come and bring me back to Brisbane in late 2000 for psychiatric treatment, because I gave away all my inheritance, destroyed my possessions and gave away my possessions, and thought I had to sacrifice myself for other people.
But the early onset basically was brought about by too much stress. I was going through a marriage separation. I was trying to work as much as I could. I didn't really have balance, and I basically burnt out physically, mentally, emotionally, spiritually as well. And then there was a component of meaning making. I was trying to make meaning of my experience, and because I didn't really seek help, I came to my own conclusions, which escalated to psychosis, like mania, then psychosis. And then you're believing in irrational, you're telling yourself irrational things that you believe to be true. And thankfully, you know, it was intervened at that point through emergency services to bring me into hospital. And my experience of that has been in and out of hospital many times, particularly in the early days. But I've had to learn and understand things for my own self.
So the hospitalisations is one point. Everyone's faced hospitalisation in the past. So that feeling of being taken to hospital or going to hospital. Did you go to hospital? Yeah.
Many times.
Yeah, so there's trauma around that with the police if they're involved, or the ambulance officers in the admission. And the experience of hospital itself is not very nice. Being locked up, if it's a locked ward with over 30 other people also experiencing quite traumatic and significant mental illness at the same time, and waiting for the medication and the appropriate treatment to start working. Yeah. So there's that acute phase. Yeah. And then also there's probably some of the symptoms as well of schizophrenia, of the hallucinations, the delusions of grandeur, building castles in the air, odd behaviour, behaviour that's not accepted by society in general, that's normal in that sense. And also a sense that you've lost your sense of purpose from being someone who could work or conduct yourself in the community and be an integral part of the community, maybe have a family. I know that I ended up breaking off an engagement because of my mental illness, long distance, and Ian's had a family but had a family breakdown.
And these breakdowns leave some people in states of severe distress, confusion and pain, which for all too many leads to feelings of hopelessness.
There is at least a 10% rate of suicide attempts or completed suicide in that population. One of the things that we see as risk factors is, suppose somebody is in college, they have their first psychotic break, maybe they're at Harvard or Stanford or what have you, and then you had to pull them out of school and they can't really return back to their normal functioning. There is this phenomenon of what we call post-psychotic depression, where that experience, whether it's the medications that's bringing them down or just the whole role transition, as I was describing earlier, is really a setup for somebody experiencing a really severe depressive episode. And that's a very important time to kind of make sure that that person's okay. And so that's one of the times where suicidal ideation and behavior is more likely to rear its ugly head. The other, I would say, is really when anybody has voices that are telling them to harm themselves or harm their other people, and they don't have the insight to know that they are voices. So the psychosis is very strong, but the awareness or insight is lacking. That is also...
What can be the cause of all these difficulties? We've already learned that the answers are complex, and so much is yet to be understood. That first psychotic episode must be confusing for everyone involved.
One of the problems is when someone comes into the clinic with early psychosis, so they've had a psychotic episode, obviously that's a very, very bad thing to happen for a young individual. They're not having a good time. You can't really diagnose them at that point. They need this longitudinal, clinicians need more information about what happens over time. Are they this, are they that? We don't know yet because we've only got this one psychotic episode. So it is a very grey zone, and it becomes more clear over time in patients, and how they respond also helps that as well. But yeah, one of the complexities is its complexity. One of the most toted lines will be it's a group of brain disorders, schizophrenia.
Our biology, the matter in our body, is constructed from proteins that are built through the expression of our DNA, our genes. So what part might genetics play? This question is also complex. Just one example is an important protein involved in the regulation of neural development and brain maturation, including neural proliferation, differentiation and migration. And it is named the disrupted in schizophrenia 1, or DISC1, and is produced by the DISC1 gene. But this gene is not the single answer. That would be too easy. there are many other problems that can occur in the genes through mutations, faults and errors.
I have colleagues that have particular genetic repositories of deletion syndrome. So you can have a 22q, your 22nd chromosome, you have on the Q loci, you have a deletion, and this deletion has a much greater incidence of things like schizophrenia. It also contains many genes that handle dopamine, and we'll get to talk about dopamine soon. So it's plausible, right? So that's clearly a genetic contribution to elevating the risk of schizophrenia. Fragile X syndrome, an extraordinarily potent risk factor for developing autism, but it is also for disorders like schizophrenia. So that's taking out or having a very unstable piece of the genome. So
the prime suspects are still in the dopaminergic systems, but now there is a focus on developmental migration of dopaminergic neurons, the impact of environmental influences, including drugs, and the resulting functionality of the whole brain system, which can vary between individuals. Daryl Isles is convinced that the journey begins very early.
We found abnormalities in how dopamine neurons start their journey in life, very early in the embryo. All of the dopamine neurons you're ever going to have in your life are born by then, first 3 months. So the exposures that are happening at a time where you're completely unaware that you're pregnant. I have to stress, if you're pregnant, don't panic. If you've got the flu, don't panic. Treat it normally. The chances of your child growing up to be perfectly normal from a psychiatric perspective are very high, right? It's just this. These are the little things that give us entrees into what might be going on in the biology, and that's where
As the researchers work towards the possibility of developing ways to stop this problem, perhaps before it even starts, medication is used to help people control the symptoms. Group help and self-help is also important. Also, the assistance of psychotherapists and counsellors who can help with lifestyle and managing social situations, and especially to help with adherence to taking medication.
So the treatment is crucial. The mainstay of treatment is really with antipsychotic medications, and those have been around since about the 50s or 60s, starting with medications that were heavy in terms of side effect burden, trying to come up with, from the first generation of antipsychotic medications, which had a lot of side effects around movement disorders and the like, to what we call the second generation antipsychotics, which reduced some of the first generation issues, but created issues of their own, including things like weight gain and everything that comes with that. And so over time, we've sort of moved towards the second generation antipsychotics, but like I said, they're still with considerable amount of side effects for the most part.
So one of the side effects of the medications that I take, quetiapine, is an increased appetite or hunger response. So that means you gain the kilograms if you eat when you feel hungry. The other challenge is with the schizophrenia is quite chronic insomnia. So that's happened in the past, and I'm suffering from it at the moment. So I take 60 milligrams of oxazepam, and it takes about 4 hours to go to sleep from taking the oxazepam at 8:30. So I'm just lying in my bed practicing mindfulness. And some nights, like last night, I had a great sleep. I got to sleep at 11, woke up at 4, went to the toilet, and then broken sleep until 8 o'clock. So for me, that was a great night. Other nights, I might only get 2 hours or none at all.
Well, mainly my side effects are drowsiness and dizziness. So I sort of look like I'm falling asleep all the time. And my family said that, yeah, I look like I'm just falling asleep, and because I'm always drowsy, so I couldn't drive. And I gain a lot of weight because that's like normal side effect, and brain fog as well sometimes. So.
There's one drug called clozapine, which is kind of like a wonder drug in schizophrenia. It's a very bad drug for its side effects, which is why it's limited in its use. And it was developed, or sort of discovered in the 60s. But for some reason, about half of those remaining people, it really helps, where no other drug does. But then obviously we still have that remaining portion that doesn't respond to any drug we have currently. And some of the work coming out now suggests that maybe that group of people who have schizophrenia but that don't respond to our anti-dopamine typical drugs, maybe don't have the same dopamine problems. So what does that mean? Well, it doesn't mean that that area isn't important. It means that other things are going on that might contribute to the same phenotype we see in psychosis. So I think in that case, a lot of the research suggests that it's not necessarily just too much dopamine going to this region. It might be more broad, sort of low-level dysfunction in a lot of regions. And the cumulative effect of that is that same response as simply just putting too much dopamine in there.
The way that you know if a medication is going to help somebody is A, does it work? And B, will you take it, right? No medication, no matter how effective it is not going to be a good one if somebody stops it after a couple of days. So the Zyprexa or olanzapine showed some promise that when you're balancing how effective it is versus how tolerable it is, then it was a little bit more worth it than some of the other ones. And I don't think that people like the idea of committing themselves to long-term treatment, right? I can't even take, something like an antibiotic for a week. That's a commitment for me. So taking a medication once or twice or 3 times a day, indefinitely is a hard thing to, well, no pun intended, swallow, right? But I think one of the things that I help people figure out is, look, this is not a death sentence. This is not the end of the world. This is something that we're going to manage together, and I like to use it.
Managing together can be achieved in a number of ways. Someone with a diagnosis of mental illness, especially something like schizophrenia, will find themselves encountering many different people. Some who they only see once or only when things are at their worst. But life goes on beyond the hospital experience or the psychiatric appointment once a month or even every 3 months.
One of the biggest gaps in care that we see is immediately after a hospital stay. So if you imagine somebody, gets so paranoid that they barricaded themselves in the room and they stopped eating for 3 days, and they're to the point where they either need to go to the hospital or something terrible is going to happen. They get into the hospital, they get started on medications. One of the wonderful things about medications for bipolar disorder and schizophrenia is that they're reasonably effective, and you can stabilize somebody in a short-ish amount of time. And short is kind of depends on who's asking the question or looking into it. And then you transition them to the outpatient setting, right? So you schedule them an appointment with a psychiatrist and a therapist, and you say, I wish you the best of luck, right? But what if that appointment is 2 months out? What if that person, as soon as they get out, maybe they couldn't fill the medication at the pharmacy? Maybe they had a side effect that they couldn't tolerate and they didn't have anybody to talk to. Maybe they just needed some encouragement to say like, hey, this is okay, we'll get you through it, right? And so we see a lot of people drop off after the first 30 days or so of their hospital stay. And then what happens? They get back into their illness, they get back into the hospital. And it can be...
The value of a GP or psychotherapist or counsellor is that they are more available, possibly every week or 2 weeks, more affordable, and have the time to establish a personal rapport, a degree of trust and collaboration in the task of staying well.
You might be seeing the person 4 times as frequently as a psychiatrist does, and monthly visits, especially depending on the insurance and the availability, you might be looking at like every other month for a psychiatrist or every 3 months for a psychiatrist. And if you as a therapist are seeing this person week after week, you'll have a better trusting relationship, and you'll be able to notice differences that the psychiatrist probably wouldn't be able to pick up on right away. So that's an excellent opportunity to not just think about saying like, you got to stay on meds, you got to stay on meds, you got to stay on meds, but just figuring out what the person wants and what the barriers are. So if it's somebody who says, look, I want to be able to work again, that's my goal. You think about, well, what's getting in the way? Is it the illness? Are you getting so paranoid that you're leaving your job and getting fired left and right? That's one thing. Or is it the treatment? So maybe the illness is under control, but your medications are so sedating that you are sleeping in and not getting to work on time, right? And if you're looking at both of those aspects, both the illness itself and its treatment, and figuring out what are the barriers to achieving what this person wants, then you build that alliance with that individual. And you can help them kind of achieve their goal by addressing which area is the most of a hindrance to their recovery and their goals.
And I think when it comes to relationships, there's things that are imposed on you. You know, you have to learn the place that professionals, the clinical kind of relationships that you have. You find that can be hard to kind of feel like, oh, I've got to go see the psychiatrist, I've got to see the psychologist, and you know, for me, I remember the idea, like, at some point, because it was a struggle in the early days to meet these appointments, I did go, and then I eventually said to myself, well, I've got nothing else, this is all I've got that can maybe make a difference for me. So I was kind of like reframing my perspective around going, because even though it was a challenge for me to get up out of bed at that point in time and go to these appointments, it's like I gave myself a reason and a purpose. That someone said to me a long time ago that the majority of people care. So I just take that on board, that these people are in the position of treating people with some kind of illness because they care.
Psychotherapy can have its limitations for some. Risa found talk therapy not so valuable when the therapist remained focused on the problems.
The truth is, it's very helpful, but after a time, you just don't want to talk about your problems anymore. So it's sort of like you want to move on and talk about your goals now, and talk about positive things now, and talk about better futures or better plans. So you want to leave it behind, sort of, after a few times of psychotherapy, you know what I mean? And you can't really pay someone to talk about your goals and your dreams, isn't it? It's not really beneficial for the psychotherapist and not really beneficial for you. But I think in a way, there is a time when you really have to move on from just the negativity of your life and starting to think about the positivity that's going to unfold in your life eventually. Even though your life is a mess, it's gonna, because life is up and down, and it's like a crest and an ebb and a flow, and you know that things are gonna get better. So why?
People find comfort and support in their peers and in themselves.
It's funny, most people don't want to hear it from a psychiatrist. I'm sorry to say that, but they like to hear things from their peers, right? So one of the things that we see a lot of the times in the hospital setting is a lot of the hospital-based work is group therapy. And I've seen over the years that people tend to do better and process differently and come to acceptance faster if they see someone else who's like them, who's getting help and is understanding their own illness and saying, hey, I'm managing this, so can you.
Welcome to Stepping Stone. We're a community of lived experience of mental illness. So we have a psychosocial rehabilitation program that we offer to those people in the community who have lived experience of mental illness, who we call members, who become part of Stepping Stone. We're a pre-vocational program, which means we focus on the strengths, talents and abilities of members and welcome them into the community and make them feel wanted, needed, expected and valued.
Getting involved in Stepping Stone, I think that's like just to live a normal life, to be involved in that, in the men's group, and living life a day at a time. I don't like to plan too much ahead. Just taking each day as it comes and doing the best with what I've got.
The community here, we've got different backgrounds in Chris and Ian and myself, but it's a really inclusive community. We have many people who have different diagnoses of mental illnesses, and it's a great community to belong to come and be accepted for who you are and where you're at. And having Stepping Stone as a support service means that I can go and engage as much or as little as I want each day. And that gives me the greatest freedom to express myself and be part of the community, even if I'm having a bad day and had chronic insomnia the night before. That's a really critical part of my recovery and my managing my symptoms. And also going for a walk in the morning and the afternoon or evening have some physical exercise to get myself tired.
Going for a walk is one of the basic recommendations a psychotherapist might give. It promotes movement and interest by engaging in the environment and can stimulate brain activity and the neurochemical needed for brain plasticity, brain-derived neurotrophic factor, or BDNF. Having community seems to make it easier to be self-directed and make decisions about how to manage symptoms.
I play sport and I go to the gym and I go for a walk or a jog or something, go bushwalking, go swimming, so it's quite fulfilling to be able to be active in that way again. So that keeps me well, and if I can make a difference to my peers in that respect of imparting something of my experience around the struggle to know what it's like to get up and go for a walk and know how hard that can be, but to try and encourage and motivate or inspire and provide some kind of awareness around the knowledge behind it. You know, that's where my passion, or that's where my love of physical activity can make a difference in my life by making a difference to other people's lives.
Even the voices can be put in their place when the circumstances are right.
I've learned how to differentiate between which voices I need to follow and which voices I need to disobey, kind of, yeah. You have to learn over the years how to differentiate between what matters most and just the chatter. And you have to learn to navigate the chatter and sort of if they tell you you're worthless, the voices tell you you're worthless, you just say to yourself, I'm a powerful spiritual being. You just, like negate it and just say, no, I'm not that person, I'm this person.
Yeah, it's been very rocky at times, when I've had those vulnerable times in my life of irrational beliefs. And part of me is reflective, and thankfully that enabled me to learn eventually, these are my symptoms, I need help, So I would be reflective of, last time I experienced this, I ended up in hospital, so maybe I need to take myself to hospital. And that was the beginning of insight into my illness. And eventually I got back to a point where I was working and supporting others, my peers, in their recovery journey, doing peer support work. And that opportunity gave me further knowledge of myself in my journey. It helped me to understand the principles of recovery. And that's what I like to share with others, because,
And the benefits of connection and support extend beyond just the personal into the spiritual. Although this may not be the same for everyone, it can be an important part of making sense of experience.
Sometimes, even though you're atheist, there's still like a creator there, an inner source of power from the creator that gives you that inner ability to just navigate your way through the darkness and light the path for other people. And for me as well, it's important that you share that light with other people. That's why we've created the Blue Phoenix group with speaking engagements and changing perceptions of mental health.
When I come into when I've learnt to be understanding of what it means to have a faith and what that is in my life, and own that for myself rather than trying to impose my ideas onto others. But what it does is it grounds me, and instead of being that square peg trying to fit into a round hole, my faith helps me to understand myself in a spiritual sense, where I become that round peg.
I've had on my heart to start up a prayer group, and these guys have joined the prayer group specifically for Stepping Stone, for members, and find that's a good way to give something back to the community, to come together and meet prayerfully, and just a good place to hang out, but it's also a good place to, give back to the community.
I've had an established relationship with a private psychiatrist now since 2008, and I talked to him openly about going to church when I went to church, but it's never been the main focus of my time with him. He's there for the medication, and I'm gracious enough to accept his help when he offers it.
Schizophrenia is clearly a disrupting brain disorder that interferes with a person's ability to think clearly, manage emotions, make decisions, and relate to others. The statistics show that less than 1% of the population develop ongoing schizophrenia, but many more experience one or more psychotic episodes that can be related to other issues, including reactions to recreational drugs or side effects of infections and fevers. Tens of millions of people worldwide are affected. It is one of the most disabling diseases affecting humankind, but the work to understand what is happening in the brain continues.
We'll get there eventually, but timing is everything in forming a brain. And if I get there late, my connections are going to be late. And this is something this is such a complicated process, we don't understand this yet. So all I know is that with one particular model at the moment, the receptors are not being made to say, come hither. That's what I know.
That's why you've got to bring it back down to some core things we know. And a lot of people, if we look at psychosis, which is, as I said, not specific to schizophrenia, but if we look at psychosis, we know a lot of people, and we can induce psychosis with this dopamine system. If we look at some of these cognitive problems, maybe if you look at the approach in America, the RDoC system, which is not looking at disorders, it's looking at underlying neurobiology. So what disorders have a working memory deficit, say? Let's learn about working memory deficits, and then they might apply to these different disorders.
There are some conditions in psychiatry that we can treat sort of simultaneously. You start one medication, you get a pretty reasonable and quick response, you add on another medication. I think in the psychotherapy realm, it's going to be a lot of work focusing on okay, maybe now is not a great time to focus on trauma. Let's figure out how to work on coping skills. And then we can sort of revisit the trauma once we're out of this particular crisis.
And as the research continues, managing the experience of schizophrenia and associated psychosis disorders comes down to the individuals who, as we have seen, just want to get on with life as best they can. It is their personal wisdom, resilience, and determination that allows them to live with schizophrenia and to create meaningful and purposeful lives.
It became more undeniable for me that, there's more to life than just the human nature that we understand, and that each person has their own understanding, and not to try and force that on others.
I think we all struggle with something, it doesn't matter what it is, but it's learning about coming together. And I think the misconception is that people need to go it alone, or they too proud to ask for help, but I think at the end of the day, we need help from each other. We're not islands.
My mental illness has been a spiritual awakening as such to the connection, the interconnection, and the interdependence of everyone all over the world, like humanity in general, and not just to human beings, but also to animals and trees and plants and microorganisms and the universe in general. And my message is because of my schizophrenia, I know that we're one family. All of us are one family, and I think it's time that we sort of work together to bring peace here on Earth instead of fighting again. This is the 21st century.
Some people view mental illness as someone's being weak, not coping, they're, not functioning right. People with mental illness have emotional resilience, they're strong, they've got character, and they can do things just as anyone else can do things. There's not a glass ceiling on mental illness. So some of the great painters, architects, musicians in history have been those who've had lived experience of mental illness, maybe schizophrenia, maybe depression. So there's not a glass ceiling on what one can do with mental illness.
It's been accepting of one another for where we are in life and what life teaches us and what we can learn from others. And no one has all the answers.